Just try to put this. Okay. Hello, everyone. I hope everyone's doing great. Like Jeremiah said, today we're going to have a discussion about diabetes. Disclaimer, my talk is going to be mainly focused on diabetes type 1. However, if you have questions about diabetes type 2, I'm more than happy to try to answer them. In that regard, if you have any sort of question throughout my presentation, please feel free to just interrupt me. If not, again, I'll be more than happy to address your questions at the end of the presentation. Okay, so to begin, I would like to start off by taking us back to our childhood cartoons. For me, for example, I was deeply in love with Popeye. I think he was a great influence in my childhood because my mom would always tell me that if I want to have energy, I would have to eat, you know. So we see in this small diagram that I have here for you that first Popeye is kind of tired. There's no food. He's tired. And then whenever he's about to get ready for action, he decides, I can hear someone's microphone.
Yeah, C's is on. I muted him.
Okay, there you go. Anyways, so when he's getting ready for action, he goes and eats, and eventually he has the ability to defeat his eternal opponent, right? And some of the truth behind this cartoon is, well, one, you can do crazy things for love, like Popeye. He would always get in trouble to get the girl of his dreams. But most importantly, we do need to eat something or provide our body with energy so that it can perform its functions, right? So in such a delicate system, we know for a fact that our diet has three main ingredients that provide our body with the nutrients necessary for it to perform its functions. Primarily speaking about carbohydrates, proteins, and fats, okay? We know that our diet has these three components individually or combined. And more importantly, our body has developed this very, very complex system to take this chunk of food, chop it into pieces, and provide our body with the right ingredients, again, to perform specific functions. In terms of energy, our body highly depends on carbohydrates to produce the energy required for any sort of activity that you can think of. We can think from body temperature regulation to exercise to anything, the ability of your heart to pump anything or any sort of energy that our body has or requires comes again from this source of nutrition. So my talk today will be primarily focused on how carbohydrates go into the body and how they can affect or help our bodies get energized. Okay, so going deeper into the digestive system, there's this organ that sits right behind the stomach. Its name is pancreas, and it has a convolution of cells, mainly the beta cells and the alpha cells. Essentially, the main function of the pancreas is whenever you ingest carbohydrates and the glucose levels in your bloodstream are high, it is responsible for secreting insulin, and in the process of secreting insulin, allowing that blood glucose to go into your cells and again be utilized to produce energy or be stored for later processes that might require energy. Okay, again, my talk will be primarily focused on the beta cells and the insulin in this regard. Now, everything's great whenever our beta cells have the ability to produce insulin on a regular basis, but what would happen if this tightly balanced equilibrium is in jeopardy? Well, turns out that when this balance is in jeopardy, we end up developing diabetes, okay? Diabetes can be categorized as a metabolic disorder. You have diabetes type 1, which is basically no production of insulin at all. You have diabetes type 2, in which your body may or may not have the ability to produce insulin. And then you have idiopathic diabetes, in which your body, there is no beta cells to begin with, okay? In that regard, Diabetes type 1 can be categorized as a metabolic disorder in which your own immune system, these activated B cells and dendritic cells, have this interaction with CD4 plus and CD4 plus T cells. And the mechanism as which this works, when it works, how it's activated is completely unknown. But we know the diabetes type 1 happens to destroy, or this type of T cells happen to destroy the islets of the B cell in the pancreas. As a result, there's literally no insulin to be produced in your body. Now, a fair question to ask would be, well, how would you diagnose? How would you, if a patient comes in and he shows symptoms of diabetes, how would you be able to predict whether or not this person has diabetes type 1 or diabetes type 2? Well, the truth of the matter is that there's 4 very distinctive biomarkers by which doctors can predict the presence of diabetes type 1 in your body, okay? These biomarkers are what our immune system recognizes as an antigen, but in reality, there's, again, 4 main ingredients in the pancreas that are attacked or are believed to be attacked by the immune system, those being obviously insulin. And then we have glutamic acid decarboxylase 65. Is for the people that are kind of new like me, this particular enzyme is in charge of converting glutamic acid to gamma amino butanoic acid, which is the main neurotransmitter of the central nervous system. We have then insulinoma associated protein 2 that we can see right here. That's a controlled growth factor. It has been found in many different hepatic and pancreatic tumors as a controlled growth factor. And then we have a transmembrane protein, SYNC transporter 8. Again, all these 4 moieties are recognized by the immune system as an antigen, so it produces antibodies to basically deplete or reduce the presence of this in our body. In other words, this work as biomarkers. If you have symptoms of diabetes, you go to the doctor, and chances are that you might get tested to see what's the population, what's the count of this in your bloodstream. Okay. Okay. Diabetes type 1 can be basically diagnosed into 3 stages. The so-called pre-diabetic, in which you have autoantibodies primarily for insulin and glucose decarboxylase 65. Those are the first 2 ones to appear. You have obviously beta cell loss, but you don't present any symptoms. Okay, at this stage, you might wonder, how in the world would a doctor know that I'm this particular stage? Well, let's say, for example, you go to a physical and they take blood. Turns out that they realize that you have this autoantibodies present. Well, that's a red flag. And then you will go into stage 2, in which you start presenting poor glucose regulation in your bloodstream. Okay. At this stage, there's a possibility that you might have 1 or more biomarkers or antibodies for those biomarkers. And then stage 3, in which you basically have the symptoms, your body no longer produces insulin. You're constantly in a hyperglycemic state. And some of the symptoms, for those of you guys that are not aware, is basically the constant need to go to the restroom, constant desire to drink water, fatigue, being hungry all the time. Now, there's a misconception regarding diabetes and the type of population that it tends to affect. I don't know if you ever heard of people. Sometimes we're so ignorant that we say, well, if you're obese, chances are that you have diabetes. Well, with diabetes type 1, it's a different story. As a matter of fact, one of the saddest things about this particular disease is that it tends to affect young people. Okay, it tends to affect people between 15 to 25 years old. Well, obviously, depending on the demographics. That's why I'm showing you guys this map. As you guys can see in this little square right here, we see that this is the ages by which diabetes might be diagnosed. So it's very impressive, very sad to see. For example, in the U.S., you might have patients diagnosed with diabetes as early as 10 years old. Okay. Now, as any other disease, we hope to have some sort of treatment. What would be the treatment of option for diabetes type 1? Well, it's kind of intuitive if you hear from me the fact that you have low insulin in your bloodstream. What do you want to do? Well, supplement insulin to your bloodstream so that it can do its job of allowing the glucose to enter the cells where it can be eventually broken down, whatever. Now, this was not always so easy. As it turns out, it took a while for scientists to discover the sequence, the structure of insulin. In fact, it was Dr. Sanger in 1957, the first person to discover the amino acid sequence of insulin. As a matter of fact, he won the Nobel Prize for this discovery. And after then, new technologies were developed to now be able to produce insulin in mass quantities and use it to treat patients. On the right, you guys see that there's, I've included a table of common diabetes treatments. And the first thing that came to my mind is, well, if I have low insulin levels in my blood, why just don't inject insulin all the time and that'll cure the problem? Well, turns out that most of the treatments for insulin are subcutaneous injection, okay? So insulin in nature is a monomer. The bioactive insulin is a monomer. However, whenever you inject it subcutaneously, insulin in the presence of zinc tends to aggregate in the hexamer, okay? Whenever this happens, this hexamer cannot penetrate the capillaries of your skin, so it takes a while for native insulin to be able to reduce your glucose levels whenever it's subcutaneously injected. However, as you guys can see from the table, we have like rapid acting, short acting, and whatnot. What scientists have done is, well, they have slightly modified the amino acid sequence of insulin so that whenever it's subcutaneously injected, the deformation of the hexamers is disfavored. In other words, they remove any sort of hydrophobic interactions, amino acid interactions, so that whenever you inject it, it remains in the monomeric form. It goes into your bloodstream and it treats the high glucose levels. On the other hand, you guys see here the long acting. So that's a little, goes backward to what I was trying to say. Now, I have a bunch of glucose. I want it to disappear as soon as possible. Well, turns out that what would be the case whenever you go to bed at night, you want to inject something that has the ability to protect your glucose levels throughout the entire night. Well, that's why we use long-acting insulin. How does that work, though? Well, in the first case, we modified the amino acid sequence to disfavor the formation of the hexamers. In the long-acting, however, scientists have developed techniques by which insulin will bind to endogenous proteins such as albumin. So you increase the half-life of insulin, and as a result, it has the ability to treat or to remain in the bloodstream for longer periods of time. Okay. Now, what are the main ways to treat diabetes nowadays? Like I told you, long-acting, short-acting, rapid-acting. Well, most commonly used treatments are subcutaneously injected, which kind of sucks. Why? Because you leave the patient with the responsibility of treating their own disease. Okay. I was reading a blog about diabetes, and there's people that mentioned that they go through 3 to 5 injections of insulin a day to kind of keep their glucose levels down. If you would imagine, that must be very painful, right? On the other hand, we have this, this, by the way, is called open loop, in which you allow the patient to basically treat himself. And then you have the closed loop, in which you use this insulin pump that is like artificial pancreas, or it serves the function of an artificial pancreas, in which it's constantly monitoring the glucose levels in your body, and it's constantly releasing insulin so that any sort of glucose that is present in your bloodstream is regulated. Okay. The problem with these pumps, however, as you would imagine, they're ridiculously expensive. So let's say, for example, you're in a third world country like Mexico. You have children that have diabetes. Chances are that their parents won't be able to pay for this sort of treatment. So that kind of sucks, right? So to put this in a more experimental context, how would the open loop versus a closed loop look in an experimental setting? Well, I found this article in which authors decided to treat diabetic rats using either the open loop or the closed loop. And this is basically the treatment schedule, okay? They would inject the open loop at 9 o'clock in the morning. And then at 5 hours later, they would measure the insulin levels in the blood, the glucose levels in the blood. And then 22 hours later, they would do the same. And they would obviously compare it against non-diabetic rats. So basically think of this as how does the open loop and the closed loop have the ability to reduce the glucose levels throughout an entire day, okay? So we see here on the right that, like I said, they went ahead and injected this in diabetic rats. And as it turns out, well, the controls we see, non-diabetic, obviously, there's little to no insulin present in the blood. On the other hand, you, as a function of injecting, as a function of the insulin being released subcutaneously or entering the bloodstream, in both the injection and the pump, you will see an increment. As you guys can see, obviously, by a single injection, the dose will be relatively higher. On the other hand, the pump remains in a very steady release of insulin. That's why you see this one slower. And they check this over a period of 28 days. However, it's important to mention that the injections took place every single day, and the pump would be constantly loaded with insulin. So the pump did not afford the 28-day treatment on its own. It have to be constantly charged with insulin. And then this is 5 hours after injection, and this is 22 hours after injection. So as you guys can see, definitely the pump performed way better as it remained or had the ability to retain the glucose levels steady throughout the entire day. Then they moved on to look at the blood glucose levels in the same mice treated with both options. As you guys can see, obviously the non-diabetic mice it's constantly producing insulin, so all the glucose that is present in the bloodstream will be eventually will go into cells, right? So the very interesting thing to look at this experiment is the ability of the pump allegedly to behave very similarly to the non-diabetic mouse. That's essentially what we want to achieve on a regular patient, the ability of the treatment to maintain or basically maintain the glucose levels at its lowest. On the other hand, you guys can see the diabetic, obviously in a very, very terrible position. The glucose levels are extremely high. And the injection, first has the ability to kind of reduce it, but it takes much more time to go to the desired glucose levels. This, again, is at 5 hours. And this one is a 22 hour in which we see that the pump, again, heavily outperforms the injection. The other thing they wanted to try, well, as you guys know, there's three mechanisms by which our body handles glucose, okay, or glucose levels. First, you have the glucose production in your liver. Second, you have this glucose intake by liver, muscle cells, and fat cells. And then you have the production of insulin by the beta cells, right? So in the second process by which your cells take up this insulin and they store it for later usage, possibilities are that you experimentally might see an increment in weight of your sample population. So as you guys can see here, the pump, again, close monitoring the body weight of the rat, the pump has somewhat the ability to replicate the non-diabetic mice on a regular diet, in which the glucose is going into the cells. Obviously, the rat requires some degree of energy. However, not all this glucose is used, so somewhat stored, and that's why you see an increment in weight. On the other hand, the diabetic and the injection do not have the ability to store this glucose in the cells as a result of not being able to fully regulate the glucose in the bloodstream. Very important test for any sort of diabetes experiments is the glucose tolerance test. In this particular case, they did an intraperitoneal in which you basically inject a head crab of glucose into the bloodstream, and then you monitor it for a period of, I've seen people go from 1 hour, 2 hours, so forth. It all depends on your system. So in this particular case, you have your animal in a non-fasting diet. Essentially, there's no sugars. There's nothing other than water. You inject it with glucose, and then you look at how your system has the ability to outcompete or to reduce the glucose levels in your bloodstream. So as you guys can see, the diabetic obviously is in a lot of trouble by injection of this glucose. On the other hand, one thing to mention is the pump. So you have a steady state of glucose delivery in the bloodstream. So whenever of insulin. So whenever you supplement glucose, you don't go through a spike. Whereas, for example, the non-diabetic mouse, there's little to no insulin present in the bloodstream. You supplement it with glucose. However, it has the ability to naturally bring those values back down to normal. Another thing to mention about diabetes is the fact that it will produce heavy hepatic stress, and anything related to your digestive system, organs, epithelial cells and tissue will also suffer from this sort of oxidative stress. In other words, this constant high glucose levels in your bloodstream will create or will promote the production of reactive oxygen species. And as we know, reactive oxygen species in the cells are a bad sign, so are terrible. So as you guys can see from this example, what they wanted to look at is if we have this pump or this injection, and we're allegedly reducing the glucose levels in the bloodstream, if we were to look at the reactive oxygen species, we would be able to see whether or not the tissue is stressed. So as you guys can see from here, this is hepatic cells, non-fixed. They're basically incubated with this dye. I forgot the name of the dye. I don't know. I don't quite remember the name of the dye, but however, as you can see, the diabetic has a high degree of reactive oxygen species. The injection is somewhat close. However, the pump and the non-diabetic mouse are close to each other in fluorescence intensity. The same is applied for this omental tissue. Again, you see high degree of stress in the diabetic, the injection. However, on the pump and the non-diabetic, the stress is minimal. So to continue on, we have then macrophage presence. One of the problems with the with diabetes is that it will promote chronic inflammation of the your liver and the omental tissue. So basically, this study reflects again an investigation to see whether or not there was high degree of macrophage presence in the tissue, and similar to what we saw for the reactive oxygen species, authors argue in the diabetic and the injection, there's a high degree of macrophage, whereas in the pump, there's really none. Jenica, I saw that you posted a question. I'm going to address it at the end. I'm going to go back. Sorry. I'll address it at the end. Okay. So going into new technologies for the development or the treatment of diabetes type 1, again, going back to the fact that the pumps are kind of expensive and the injections are painful, there's been a lot of research done trying to create alternatives that are safer, that basically provide the patient with a better quality of life. And people have extensively investigated polymers for this particular matter. Okay. Right now, I'm going to present to you this research, very interesting research in which authors use PEG. So think of this as a polymer liposome kind of a deal. Okay, you have this pegylated moiety with phenylboronic ester. And then you encapsulate insulin and glucose oxidase. You may wonder, wait a minute, why would I encapsulate glucose oxidase? What's the purpose of that? Well, very simple. Glucose oxidase, it's an enzyme that catalyzes the oxidation of glucose to gluconic acid. As a result, you're going to have a pH drop. That pH drop will basically you'll create a pH drop, but one of the byproducts of this oxidation is hydrogen peroxide. This hydrogen peroxide basically disrupts the interaction between the phenylboronic ester and the PEG. So this is water soluble. This is amphiphilic. So you have a moiety that encapsulates glucose oxidate, and insulin, right? So you have a bunch of glucose. It comes in. It disrupts the interaction of the phenylboronic ester and the PEG. As a result, in very simplistic terms, you release insulin. So this is stimuli responsive. Have you read on diabetes tissues? Yes, I'll talk about that in just a second whenever I am. So we have this glucose increment. You have hydrogen peroxide dissociation of the polymer, insulin release. Okay, very, very simple. So in this particular case, we look at the characterization of the nanoparticles before the encapsulation of insulin and glucose oxidase. Authors ran transmission electron microscopy to determine that their method, solvent evaporation method, by the way, afforded this 200 nanometer nanoparticles. And then they encapsulated their glucose oxidase in the insulin. They saw an increment in size of approximately like 20 to 25 nanometers, as you guys can see from the dynamic light scattering profile. And then they went ahead and quantified or looked at the a release in vivo. So again, this mechanism fully depends on glucose. High glucose concentration in whatever medium will promote the degradation of the polymer, and as a result, the release of insulin. So as you guys can see from this chart, PBS has a very small effect on the insulin release, whereas you have the normal glycemic insulin levels, which are 100 milligram per deciliter of blood, and there's somewhat a release of insulin. However, whenever you expose your system to a hyperglycemic case scenario, you see this nice release of insulin. The other thing that I thought was very interesting, they varied in a different experiment, obviously. They varied the concentration, or they had like a gradient in which they wanted to test the insulin release as a function of varying the concentration of glucose. So whenever you guys see the label of this is polymer vesicles, I'm sorry, and this is enzyme plus insulin, so glucose oxidase plus insulin, and then they also looked at half the encapsulation of glucose oxidase in insulin. So as you guys can see, at normal glycemic, you have barely insulin released from your system, and then you start increasing, and as a function of an increment in the glucose, you afford more insulin out of your system. It was very interesting to see that they agreed that there was a linear correlation between the amount of glucose oxidase in the system to the amount of insulin released in vitro. Another very interesting thing they did in vitro again was just look at bearing to see if there would be spikes, or how would the system behave as a function of back and forth changes in the concentration of glucose. So as you guys can see, here, normal glycemic, it goes up, and then you basically extract this high degree of glucose, and your system goes back down, back up, back down, and back up. Another very interesting thing, in which I thought, to me, it was very hard to believe, was the fact that they're using heavy organic solvents to afford these microparticles. However, they argue that after release in vitro, they were able to replicate the circular dichroism profile, in which we see that insulin retains its high degree of alpha helix content. Okay, in other words, the protein that was encapsulated and released is still in a native form, able to decrease the glucose levels in your bloodstream. So now that they've heavily characterized their particles, they decided to then dope or just deposit these formulations into microneedles. These are 20 by 20 microneedles made out of HA acid. It's cyanuric acid. I don't quite remember the name. Before testing in vivo, they doped the insulin with FITC. And as you guys can see, or the argument the author is trying to make here is the fact that, well, the deposition of the microparticles in the needles afforded a uniform microneedle loaded with insulin. As you guys can see from this, they went ahead and tested this on mice, and they did H&E staining to just look and see if the microneedle does in fact have the ability to penetrate the skin. I thought it was very interesting that authors argue that after 6 hours of removal of the microneedle patch, there was no longer any signs of injury or entry in the skin. So the argument I'm trying to make is that this microneedle patch doesn't really affect your skin, and your skin can recover very fast. Then we look at the in vivo characterization they did on diabetic mice. So interesting to see, again, that this MNHA is just empty particles, empty microneedles, okay? That's why you see that the glucose levels are not decreased at all. And then you see your microneedles with the polymer vesicles and insulin on its own. Somewhat has the ability to decrease the glucose levels. You have the microneedles with in green with the glucose oxidase and the insulin. So essentially, you have a high degree of glucose. By the idea that glucose will come and cleave the polymer, you have the ability to decrease the glucose levels in your bloodstream. And obviously, compared to your native insulin, in which they argue, well, the insulin will act very rapidly, but it will not have the ability to retain this prolonged normal glycemic state in the diabetic patient. The other thing they wanted to try, well, we are putting this microneedle patch on the mice, and the mice is supplemented with a high degree of glucose. What's going to happen? Well, again, this is an intraperitoneal glucose tolerance test in which they realize that, again, in the high glucose environment, the insulin will be delivered or released from the microneedle, as we can see from here. Whereas your microneedle with insulin does not have the ability to respond so well. This was further complemented by blood glucose levels, as you guys can see here. In other words, the intraperitoneal glucose tolerance test, you inject. They don't compare it to the pump. No, Michael, I'll answer the question. No, they did not compare it to the pump. They're comparing just to the healthy mice right here, non-diabetic. So blood glucose levels in the presence of an intraperitoneal glucose tolerance test, as they argue, their microneedle with glucose oxidase and insulin has the ability to kind of contrast the glucose levels. And whenever you just have the microneedle with insulin, for some reason, it does not have the ability to bring the glucose levels down. Now, what would happen if you put this system in a mice that has no diabetes? In other words, if there's normal glucose levels in your bloodstream, is there going to be a hypoglycemic state? Well, as you guys can see, if you inject insulin in the microneedles, this insulin will be released. It creates a hypoglycemic state for a certain period of time. Whereas whenever you have the microneedles with the glucose oxidase and the insulin, you maintain a normal glycemic state. In other words, kind of showing that their system works whenever there's only high glucose levels in the bloodstream. And this data is complemented here by the area under the curve, in which we see this hypoglycemic index. Again, insulin on its own has, whenever you inject it in a normal animal, you're going to create a hypoglycemic state, whereas your system that is stimuli responsive does not really affect the glucose levels in the bloodstream. A different study, a very interesting study, was now to use a different type of particle, different type of approach. In this particular case, they use dextran as their polymer of choice. And they basically played for having either acyclic or cyclic acetyl content along the polymer. Why would you do that for? Well, as it turns out, that again, the construct had glucose oxidase. So again, glucose oxidase in the presence of glucose will bring the pH down because glucose goes from glucose to gluconic acid. So this acetyl groups will basically be cleaved off. In other words, you dissolve the polymer, again, in function or in response to a pH drop, which is caused by this enzymatic activity of glucose oxidase. So as you guys can see from this particular case scenario, before even including any insulin or glucose oxidase into their system, authors wanted to see at which degree of decoration of this dextran with the acetyl content would they be able to afford a prolonged insulin release. In other words, they wanted to have some sort of short action, long action. I don't know, Michael. Anything lab? I have no idea. Okay, so authors wanted to kind of look at what content of acetyl moieties will they be able to afford, again, a short-acting and long-acting insulin-responsive material. I'm sorry, glucose-responsive material. So you see here, their first in vitro testing was looking at soluble dextran. In other words, whenever you have this construct, for example, this or this is not soluble. These two components are not soluble in water. However, whenever you remove the acetyl content, this will go into solution and you can quantify the amount of just the dextran. And this is basically what they did at different pHs. Again, this is pH responsive. You cleave off, your dextran goes in solution. So what you guys see here, C refers to cyclic, and they vary the ratios of cyclic to acyclic acetyl content. So basically, if we pay attention to this graph, we look at the fact that by increasing the cyclic content, you get to afford a more prolonged or a more resistant polymer in the presence of a low pH, whereas obviously in physiological conditions, either the lowest two decorated cyclic dextran moieties can really perform well. The other thing they looked at was if this solubility is true, we should see that in the presence of a low pH, the particle should go from a well-defined sphere, or as you guys can see from here, it should go from a defined size to something smaller and smaller and smaller because you're losing the polymer content. And as we can see from this graph, so the inset is the native particle before exposure to low pH, and then they expose it to low pH, and we see a drop in size. Okay. Then we see the insulin release. If we just have 55% of cyclic decoration on this polymer, we notice that there's going to be a high degree of insulin release very rapidly as a function of low pH. Whereas if you have this 71% of cyclic decoration, you might afford to retain the insulin within the polymer for a longer period of time. Okay, so again, this is just based on buffer. Now they wanted to test this using now glucose, because remember we have glucose oxidase which will create a pH drop that will result in polymer degradation. So we see that no glucose, the polymers perform perfectly fine. There's allegedly no protein release, whereas you are in the normal glycemic values, and there's some degree of protein release. Finally, whenever you increment the glucose concentrations in your system, obviously you will degrade the polymer way faster, and as a result, release the insulin or whatever protein much faster. Now, they wanted to kind of look and see, okay, if our approach is to have a short-acting and a long-acting, how about the combination of the two? In other words, how about if we, by equal mass, we basically have 55 and 71 decorated cyclic strand? What would be the outcome? So you guys can see here at pH 7.4, the system performs well, whereas you decrease the pH, now the system will rapidly release the protein content. Recreating this sort of experiment, they decided to now try with different glucose concentrations. And again, we see that at a low concentration, normal glycemic, there's minimal protein release, or it takes a while for the protein to be released, whereas whenever you increase the glucose, it's much faster. So yeah, the other thing they wanted to try is after this long decoration, long construct synthesis, is the insulin release still active? And by circular dichroism, they were able to show that the insulin is still bioactive now. It's important for me to mention that you guys see the label of trypsin. Why trypsin? Well, trypsin is a enzyme present in the digestive tract that has the ability to break the heck out of insulin. So they wanted to see if you have the nanoparticle just sitting there at low buffer, and you expose it to this concentration where insulin shouldn't be leaking out of the polymer, what would happen? And as we can see, that the trypsin doesn't have the ability to destroy or to jeopardize the secondary structure of the insulin sample present in the polymer. The other very interesting thing that they did is, okay, we're gonna be injecting this polymeric material. How do we know that this polymeric material itself is not toxic? Well, they just looked at the local inflammation at the site of injection, and they quantified four different pro-inflammatory cytokines, also known as I-beta, IL-6, IL-12, and TNF-alpha. Interestingly enough, their control, very important to mention, there's two very interesting controls. Your naive mice, nothing injected. And then their control, the other control is lipopolysaccharide, something that will basically create heavy inflammation or high stimulation of this for pro-inflammatory cytokines. So as we can see, these are empty dextran nanoparticles with a combination of the 55 and the 71 cyclic decoration. As we can see, there's basically low cytokine production, which is correlated to the fact that obviously whenever you inject it at first, you will somewhat have this presence of IL-B and IL-12. However, at 24 hours, the levels of IL-6, TNF-alpha, and the rest of the cytokines shouldn't be so high. In other words, there's no serious inflammation or toxicity associated with their own, with their empty polymer vesicles. And the other thing they did, they had this PBS injected mouse in this empty particle or empty vesicle injected mouse, and then after 28 days, they sacrificed the mice, and did H&E staining just to look at the neutrophil presence. And what they're trying to argue with this set of data is that the material itself is not really creating any sort of tissue injury. Finally, they evaluated the ability of this system to perform in vivo. And as we can see here, in diabetic mice, Three different things were tested. Your empty particles obviously do not have the ability to fight glucose. And then you have your insulin, naked, meaning just subcutaneously injected insulin, which again has the ability to rapidly remove or decrease the glucose blood glucose levels. However, it has a tendency to see progression or increment in glucose after a certain amount of time. In their system, long acting and short acting. So as you guys can see, short acting here, okay, and then long acting, where they allegedly argue that the system has the ability for at least 16 hours to keep normal glycemic controls in diabetic mice. And what would happen if you injected these materials in healthy mice? So again, your naked insulin obviously drops the glucose levels. Your system, since there's not much glucose to stimulate it, you see a less decrease of glucose levels, and obviously the empty nanoparticles do not have any sort of effect on the glucose levels of the body. Now, I want you guys to pay attention because, as you can see, this is on an hour scale, okay? So essentially, as Michael was asking earlier, we eventually want to transition into something that does not have to be injected on a regular basis. Whether it's less painful or whatever, it's still an injection. So I'll talk a little bit about another process in which they focus more on a long-term insulin release. Another very, very interesting article I found during the process of learning about diabetes is that there's been a lot of efforts trying to create oral delivery of insulin. I think whenever I talk to you guys about the different MOF platforms, you remember that I discussed Dr. Farhan's project with New 1000, which is a acid-resistant MOF. Well, interestingly, there's this liposome-based alternative in which authors decided to test what would be the possibility of using these liposomes to encapsulate insulin and seeing if it will be able to bypass this harsh digestive tract environment and eventually be able to reduce the glucose levels in the bloodstream. Important to mention that you have this liposome, okay? The liposome itself, as any other particle, will have little to no penetration on the epithelial cells of your gastrointestinal tract. However, the main or the novel thing about this article is the fact that these liposomes were decorated with biotin. It's vitamin B3, and as many of you know, vitamin B3 is not produced endogenously, so you have to take it. That means that there's there's enterocytes, these cells with a high degree or high density of biotin receptors that allow the biotin to penetrate into your bloodstream and be used for whatever purpose. So the novel thing about this article is the fact that these liposomes were decorated with biotin, so that whenever they would encounter the digestive tract by means of this surface modification and receptor interaction, the liposomes would be uptaken and allow the liposomes to penetrate the bloodstream and supply the insulin. This process was entirely done in a endocytosis-mediated cellular uptake, if you will. Okay. The first thing, these liposomes were done in the so-called solvent evaporation method, and after the synthesis or production, they were able to afford this 200 nanometer particles that they were able to kind of see in the TM. So yeah, fun fact, whenever we go downstairs and look at our liposomes, yeah, poor Olivia and Yeleni get to see this, and then this other beautiful looking or kind of one of the dispersed looking liposomes. Okay, so now they afforded these nanoparticles that are surface decorated with biotin. The reasoning behind their experiment was, okay, now let's take a look and see how our system performs in vitro. What better in vitro setting to test this other than either gastric stimulated fluid or simulated fluid and intestinal simulated fluid. So as you guys can see here, you have the insulin retained in the simulated gastric fluid. In other words, you put your liposome, okay, for a certain period of time in this harsh environment, and then you look at the insulin not bioavailability, but more like you look at the integrity of the insulin. So as you guys can see, whenever you put insulin not protected, it's heavily destroyed immediately. Whereas these formulations, this is COP, means the particles without biotin surface decoration, and BOP refers to biotin decorated liposomes. Okay, so you guys can see that the BOP has a better performance, but most importantly, to mention that the simulated gastric fluid has pepsin, another enzyme that has the task of destroying everything that goes into the stomach. So they were very surprised to find that regardless of the presence of this harsh acidic environment in the pepsin, there is still some insulin present in their nanoparticles, sorry. So then they looked at the performance of this system now in simulated, this was simulated in intestinal fluid. I accidentally didn't put the right graph, but however, they looked at a very similar pattern. In other words, in the simulated gastric fluid, it was able to perform. In the simulated intestinal fluid, it was also able to perform. So for the authors, that was enough to transition in vivo. And as we can see here, they delivered this in diabetic mice orally. So the control is insulin injected subcutaneously. As you guys can see, it rapidly drops the glucose levels, whereas your insulin solution, native insulin solution, is obviously not capable of doing anything because it's heavily destroyed as a function of the harsh digestive tract environments. And then you see that your insulin-loaded liposomes, non-decorated, kind of has the ability to decrease its glucose levels. Why? Because let's remember that this is not biotin decorated, so it has minimal or should have minimal ability to deliver the insulin in the bloodstream, whereas the biotin decorated one does have allegedly the ability to bring this to the bloodstream and treat or reduce the glucose levels for a certain period of time. Again, looking at the time scale, this is just hours, okay? Yeah, so then they looked at, So then they looked again at how long would it take for this glucose to be detected in the bloodstream. Again, orally or subcutaneously injected. Subcutaneously injected, they're controlled. So immediately after the injection, you get to see that the insulin's already present in your bloodstream. Whereas orally delivered native insulin, well, you can hardly detect it. The insulin-loaded, non-decorated liposomes, again, hard to or very minimally detected, whereas your biotin decorated liposomes, you get to see detection after approximately 5 hours of oral delivery. Now, they did a very, very interesting study. This is ex vivo, so they doped their liposomes with calcium. This is a dye, fluorescent dye that excites at 595, and emits at 515. So it's a good probe for ex vivo analyses. So as you guys can see, this is conventional liposomes, okay? Allegedly, since they're not decorated with biotin, they will have a very, very hard time penetrating or going through the intestinal tract. Whereas you see the biotin decorated, and the argument authors are trying to make is that, well, these cells are heavily filled with, or they're highly, they have a lot of biotin receptors. So as a function of that, your liposome has, or will fastly penetrate the, or bypass the gastrointestinal tract. Okay. Now moving on to the last article that I'm going to talk about. And remember what I told you. Well, all the previous articles that I talked about, yeah, they're magnificent. I'm telling you because I know how difficult it is to work with insulin. They come along great ways. Like they do have very, very good ideas. However, they do not address the necessity of having this prolonged insulin delivery. And by prolonged, I don't mean 16 to 28 hours. No, more like days. So in this last article that I'm going to present, very interestingly, authors decided to decorate insulin with PEG. Okay, we have insulin, which it's a 50 amino acid hormone. You have your alpha chain and your beta chain. So in lysine, 29 of the beta chain, they attached PEG. Okay, so PEG in this particular case scenario would serve as a hydrogen bond acceptor. And then we have this TA acid or tannic acid, which, as you guys can see, has a high degree of hydroxyl groups that can serve as hydrogen bond donors. Okay, so the idea behind this experiment was to create a layer by layer film in which there would be insulin constantly released in vivo or in any sort of physiological condition. Okay, in this particular case, we do not depend on any sort of stimulus. In other words, relating to the question of Michael, yeah, this is more directed to imitating the pump. In other words, you do not require stimulus to have insulin constantly running in your bloodstream. Again, this is fully dependent on the interaction of the PEG as a hydrogen bond acceptor, and the tannic acid as a hydrogen bond acceptor. As you guys can see here, this is the films, they layer by layer, literally films. So when exposed to in vivo or any physiological condition, you would basically, let us remember that the hydrogen bonds are reversible. So you would basically disrupt the interaction between the PEG, the tannic acid, and as a result, your insulin would be constantly released. So they tested this in vitro with PBS buffer, pH 7.4. What you guys can see here is this small label refers to 3 layers, 6 layers, 9 layers, and 12 layers of this PEG, tannic acid, PEG, insulin, tannic acid, PEG, insulin, tannic acid. So it is very clear to see that the more layers you put in, the more insulin you have to release in the long run. Okay. They also decided to test this particular experimental setting in diabetic mice. And very interestingly, they came to the conclusion that at 50 layers of the PEG, insulin, tannic acid, this layer by layer film would have the ability to maintain a high degree of insulin in the bloodstream for at least, I want to say, 17 or 18 days. They decided to move on and also look at the glucose levels in the same diabetic mice. Obviously, your healthy control, non-diabetes, has minimal glucose in the body. And look at this. So this is very interesting to see that this green arrow, or this green line, refers to the 50 layer in which they were able, again, to maintain this normal glycemic state for at least 15 days, whereas the previously examples I shared with you is just a matter of hours. So the other thing they did, which part of the particle characterization was, okay, let's take a look and see if this hydrogen bonds are in fact the main ingredient of this layer by layer artifact. And as you guys can see from this FTIR transmittance spectra, so we have the tannic acid. This is your COC stretch, and this is your carbonyl stretch. Whenever you put the PEG and the TA film, you see a shift indicating according to the authors, that there's hydrogen bond formation. So we see this one going to a higher wave number, this one going to a lower wave number, indicating that there's in fact this hydrogen bond, intermolecular hydrogen bond formation. They decided to take a look at the released insulin from the film, came to the conclusion that the device fabrication does not really alter the ability of, does not alter the secondary structure, the high degree of alpha helix present in insulin. So just to wrap up my my conversation, so we've seen that pumps or continuous delivery has shown superior treatment over single dose. So the current research is focused on mimicking the pancreatic function by having a depot of insulin available and only releasing it through stimuli promoted or high glucose levels. For the examples that we saw, and literature is filled with a bunch of examples using different polymeric matrices. And one very interesting thing that I really hope that us as a group can participate in is push forward with this, both the depot and the oral delivery of insulin, taking a look at how metal organic frameworks can kind of advance this area of extensive investigation. So with that being said, I'm going to open the floor to answer any possible questions that you might have. So let me try to go back. I don't know how to do it. Let me see here. Okay, I think I can go back here. Okay, never mind. If anyone has a question that is not in the chat that wants to, okay. So let me see. I see that you're asking.
Hey, Fabian, I have a question.
Yes.
So with the oral delivery, it looks like I want to know what your timeline is for the insulin to enter the bloodstream if you were to do an oral delivery. It seems like they said it's around 5 hours.
Yeah. So, I mean, based on the experimental setting, they argue that it takes approximately 5 hours for the insulin to go into the bloodstream, which should kind of be complementary to, or could be complemented with this ex vivo. As you can see, the fluorescence of calcium is greatly diminished between the 4 to 6 hour, indicating the possibility that the vesicle is now internalized instead of accumulated in your gastrointestinal tract. If that makes sense.
Yeah, I had a question too about the previous slide. So yeah, I was thinking about that. It looks like they went up to 4 hours with the, if you go back one slide.
Yeah.
With the SGT.
This guy?
Yeah, SGF, sorry. So that's interesting to me that it stays at like 40% for so long. Can you speak to why it would just stay at 40% for 60 minutes to 240 minutes? For 3 hours, it doesn't like show any release after that?
Okay, so wait. I see what you're saying. So I guess in this particular case scenario, your question would be like, okay, if it's there in the simulated fluid, why is not constantly released? Is that what you're trying to say?
Yeah, it just seems odd to me that it's just staying completely stable and for 3 hours, and it's just like the first release over the first hour.
First release.
Like the first hour, like it gets a lot of it is gone, and then it just stays at like 40% from 1 hour to 4 hours.
Okay, so in that particular matter, if I'm getting your question, if I interpret your question the right way, what they're trying to argue is that there's going to be a very harsh chemical environment and enzymatic environment that will basically destroy partially the insulin. However, no matter, or the argument that they're trying to make is that between 30 minutes or 3 hours, this should remain, the 20% or 40% of insulin should remain active. And that insulin that remains active should be the one eventually participating in the treatment of the glucose high levels of the blood.
Okay.
Does that make sense?
Yeah, that clarifies that for me. Okay, thank you.
So what? Yeah, okay, perfect. Let me take a look at the other questions. I don't know who's in Yep. Okay, how does the reactive oxygen species produce for diabetes? Yes, oxidative stress. Angelica, that's your question. And yeah, well, basically, these oxidative stress tends to damage the DNA strands, and I don't remember exactly what other sort of enzymes are overproduced that have very critical impact on the microcellular labs. So, Rusa, have you read on diabetes type 1 affecting tissues and causing neuropathy? Yeah, definitely. That's one of the reasons why actually I like this insulin project overall, because I had a very close friend, I don't know how long ago, I think it was like 7 months ago, and neuropathy, the guy had an injury, didn't realize about the injury. Long story short, he just recently got amputated both his legs for this diabetes type 1 chronic tissue and neuropathy case scenario. I don't know if you would like, I don't know if your question, yes, I've read about it, but I don't know if this question is more like, why does it happen? Or I don't know, but if you have a follow-up question, Perusa, please feel free to ask it.
I would actually like to know how that happens with type 1.
With type 1?
Yeah.
So you have a high degree of oxidative stress. And as I was telling you, the fact that you have a very, very hard time, your blood will have a very, 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 the blood pressure, the vessels of your, the blood vessels of your body will be significantly affected, because diabetes type 1 has a tendency to have, again, impact on your blood vessels. But most importantly, with the neuropathy, going back to the oxidative stress, is just basically the fact that this intensive presence of glucose, or either extracellular or intracellular glucose, has a very bad impact on the nerve systems. And the other thing, going back to the biomarkers that I was telling you about, this glutamic acid oxidase 65, well, as a precursor for a neurotransmitter, the fact that it's abolished by diabetes type 1 antibody production of T cells, that has a heavily impact on how your nervous system eventually behaves, if that kind of makes sense. I don't know if you would like to have a more detailed discussion about this. I can eventually read way more about this, but just very, very superficially, that's might be a concept.
No, this is great. Thank you so much, Fabian. You did a great job. I appreciate it.
Oh, thank you. So they don't compare. Michael says they do not compare to the pump or subcutaneous injections. None of the studies really talk about the pump. However, if you notice that in some of the, let me go back. For example, in this case, so this, Michael, would be your subcutaneous injection comparison. Always looking at the fact that if you supplement insulin subcutaneously, your glucose levels, your insulin levels in the plasma are going to be very high. But I didn't see anyone really comparing to the action of a pump. Is this a paper by Insulin Lab? I have no idea about that, Michael. I will follow up with that. Yeah, so those are the questions in the chat. I don't know if anyone else has another question.
Yeah, hey Fabian, I just have a curiosity. I guess while you were reading, I see that these polymer systems are basically acting like a way to deliver insulin for a longer period of time. But of course, it still seems like no matter what, you're going to have to inject daily. So I guess I'm just curious: have you come across any papers that try to target the immune cells instead as a cure?
That's an amazing question, because the new technologies, like the state-of-the-art diabetes type 1 treatments, are now focusing on this case scenario. In fact, I have a pending conversation with Jeremiah about this, in which I told him that would be worth exploring. But what I've seen is people have segments of this 4 biomarkers that I talked to you guys about. Let me see if I can go back to my slide. So what people are doing, instead of treating or just, hanging out with the diabetes type 1, they're trying to create a more realistic solution. And what they're doing, they take segments of this for biomarkers, more specifically insulin, segments of like peptides of this insulin that are allegedly attacked or recognized by the T cells. And then they're looking at how would that eventually protect the beta cell population. In other words, you kind of distract your immune system from breaking the actual beta cells by doing so, if that kind of makes sense.
Mm-hmm. I guess I'm also curious if anyone, you probably, I don't know if you would know, but I guess I'm wondering how strong of an immune response is occurring. Like, is there memory B cells being developed and memory T cells are being developed during this process? And this is just out of my curiosity. I guess I just wonder, because at the same time, I feel like if you're injecting insulin, I feel like over time you would have to probably increase the dosage of insulin because of the increase in antibodies produced against it.
True. And that brings me to one of the articles that I was reading about, because to me, one of the first questions I had regarding this insulin issue is like, well, if you're losing the pancreas or the beta cells, why don't you just have an implant? And to kind of answer your question, whenever people have done this, they realize that though you have a new pancreas in place, this diabetes type 1 will eventually develop again. In terms of the memory, one of the main sources of diagnosis, aside from the biomarker presence, is the CD4 T cell and the CD8 plus T cell presence. However, people don't necessarily know how they interact or how are they breaking it apart. But again, they do have some degree of memory to be able to further attack another pancreas in the case of a transplant, if that kind of makes sense.
Yeah, no, it does. Interesting.
It's actually very sad because there's this is by the way, this is the first non-infectious disease that is declared as a world pandemic. And the truth of the matter is that there's only been temporary solutions, but no one, like, you cannot read anywhere this works or how the immune system is so obsessed on jeopardizing the integrity of this beta cell. So yeah, I think it would be extremely nice and insightful to transition into looking at how to distract or how to inhibit the immune system from breaking the virus.
Mm-hmm. Yeah, I agree. Thank you, Fabian.
No, thank you, Michael.
All right. Fabian. Oh, sorry. Oh, go ahead.
I just realized that it's 1:48 and I was going to apologize with everyone. But yeah, go ahead, sister.
I guess quick question is kind of broad. Are there any ties between type 1 diabetes and pancreatic cancer? Like, any of that?
Well, some of the articles that I read, they talk about the fact that insulin can eventually lead to pancreatic cancer. They also, those articles play to the fact that since you don't have this insulinoma associated protein 2, this guy right here, which is a controlled growth factor, there's a high possibility, or there's at least some degree of possibility that your body might eventually, by the degree of injury, develop cancer. But I didn't look too much into it to be honest.
Got it. Thank you.
No problem. Okay, I don't think there's any more questions.
Yeah, I think we're good. All right. That was very good. And in the interest of time, let's just go ahead and say thank you and clap at Fabian and head off. All right.
Okay, sorry about that.
Very good. All right. I'll talk to you guys later.
Bye bye.